exciting lecture to do because this is the kind of stuff that we get paid the big bucks to manage, and you have to act quickly because seconds matter, seconds equal cells. So we'll talk about what's expected of us, but I did want to revisit before we talk about acute coronary syndrome, its cousin, ischemic heart disease, and kind of what sets you up for that with our check on learning. So let's go ahead. All right, so our first one was, which of the following is not a determinant of myocardial oxygen demand? Remember, we have the oxygen demand stuff, and then you have the oxygen supply factors. Which of these listed is not required for myocardial oxygen demand? So what does not impact the amount of oxygen you need to survive? Go ahead and start chatting out. Bravo, I hear. Any other answers? Charlie. So oxygen demand is how much oxygen do I need to perform the function. So things that increase oxygen demand are going to be things like the heart rate. So the faster I'm beating, the more oxygen I'm going to need to keep up with that pace, right? I'm using more, I have a higher metabolism going on basically because I'm working harder. Contractility, so that's the strength of your squeeze. So the harder that I have to squeeze in order to get blood out, I'm going to have to work harder to do that, so I'm going to increase my oxygen demand. And then ventricular wall thickness, we talked about how this is the factor where the myocytes are trying to stay in contact with each other, and the thickness or the stretch of them means more work. So you're having to work harder. But one of the things that can kind of counterbalance that is ventricular wall thickness. So I have stronger muscle in that area, so I don't have to exert as much work to maintain that integrity because I have basically more cells in that area to maintain that integrity. So coronary vascular resistance, so this is based on like how clamped down, so is it vasodilatory or is it vasoconstriction? That will impact the amount of oxygen or blood with oxygen coming into that area, right? So that is a supply factor. So yeah. It does to a degree, but it also kind of decreases it. It's kind of maybe not net zero, but it when you have like increased stretch because you have like increased preload, increased volume, the myocytes are pulling further and farther apart, and they're trying to maintain that integrity, so they're having to work harder to maintain that integrity. But what ends up happening as a compensatory change to that persistent stress is the muscle is going to thicken up. So now I have more myocytes. So instead of just this one myocyte trying to hold on, now I've got 10, which reduces that overall work and oxygen demand there. It does have a little increase from what it should be, but in all, it kind of gets it down to at least a net negative a little bit. So this is more of a management type of question, but something to think about, okay? So you have a 72-year-old man, history of coronary artery disease that presents for office evaluation because of episodes of chest discomfort. His symptoms occurred consistently during exercise and resolves with rest. So this is kind of a classic picture of stable angina. There has been no recent change in the frequency or severity of these episodes. His current medications include an aspirin 81, atorvastatin 80, metoprolol succinate 20, isosorbide mononitrate. His heart rate is still 95 beats per minute, and his blood pressure is 146/78. His EKG is normal without any signs of acute myocardial ischemia. Which of the following would be the best next step in managing this patient's symptoms? What are your thoughts? Sorry, shout out. A. Okay, correct. Yep, A is the correct answer. And the reason for that is, what is our goal heart rate? 55 to 60, right? What are we at on this? So we have a lot more room to go. And now this is maybe knowing what the max dose is for metoprolol succinate, but this is a baby dose. Okay? So we have a lot more room to go up. Now, do we think of beta blockers as an antihypertensive, especially like metoprolol? Not really, but it does have a blood pressure effect to it, right? So the blood pressure may come down. It may even come down to goal once we increase that heart rate, or increase that dosage of metoprolol and bring that heart rate down. Now, the other reason that amlodipine is not necessarily the best answer in this case is calcium channel blockers don't convey a mortality benefit like your beta blockers do. So I want to prioritize beta blockers over calcium channel blockers in this instance because of that mortality benefit afforded by the beta blocker. Okay. And then looking at the other things, so increase the aspirin dosage. There's rarely a few instances where I need somebody taking more than 81 milligrams of aspirin a day. But yes, in the acute setting, absolutely. But from a chronic daily basis, very few instances where you want to have 81 milligrams or more than 81 milligrams a day. And then D would be the correct answer if we had max dose regimen. So we were at the max dose of our metoprolol as well as max dose of our statin therapy as well. So that's why delta is not the correct answer. Does this make sense? Why beta blocker, increasing the beta blocker dose is the correct answer. Okay. All right. So we talked about ischemic heart disease, and we talked about that spectrum. Let's now talk about the acute coronary syndromes in this anginal spectrum. So we said stable angina was that pattern of predictable symptoms with exertion, right? I go up one flight of stairs, I'm okay. But as soon as I go 1 or 2 steps past that one flight, I start having symptoms, right? And then I stop doing what I'm doing, I rest, pain gets better. It's that pattern of predictable behavior. We talked about how stable angina also typically comes on around 70% stenosis of a coronary artery, right? So we do have some leeway, we have some ability to kind of adapt to that perfusion deficit. But once you get to 70%, then you start to have symptoms with exertion. But what happens if that stenosis gets worse? And now I'm 90%. Now I can get a change in my anginal pattern, and now I start to have symptoms with rest. Or maybe now, instead of being able to go up one flight of stairs before I start having symptoms, now I'm only having half a flight and I start having symptoms. I start to have this change in my normal anginal pattern of symptoms. And that is where you start to get like these acute coronary syndromes, okay? We'll talk about what kind of highlights the differences in this, but when you talk about acute coronary syndromes, you do want to categorize it appropriately because your management is going to be dependent on which version or which variety of the acute coronary syndromes you actually are dealing with, okay? So we talk about STEMIs, so the ST elevation MIs, that makes sense, right? This is, you got to act now or else the patient's going to die in front of you, right? But there is a flavor of acute coronary syndromes where you get those non-ST elevation, but it still is an acute coronary syndrome. And there's 2 versions of this particular brand of acute coronary syndromes, known as an NSTEMI, so non-ST elevation MI, and unstable angina. And knowing which one you're dealing with is important, and we're going to talk about what kind of differentiates one from the other. Okay. So let's revisit what the normal process is inside the coronary arteries, or in arteries in general. And then let's talk about what goes wrong that leads to the development of this condition. So normally your endothelium inside of your artery has these prothrombic, so pro-clotting factors, but they also have these antithrombic, anti-clotting factors. And there's this dichotomy between the two where it's like they work and say, well, I don't need the clot, so let me upregulate the antithrombic factor so I don't clot inappropriately. But now I do have some damage. Now I need that prothrombic behavior to act up and so, or increase its activity, so that way I can now clot and start healing, right? So in the normal endothelium, you have this balance between the two, and you get this appropriate regulation of this, and it leads to your overall health, right? But let me start throwing in atherosclerotic plaques into the area. Now I start getting some endothelial dysfunction because those atherosclerotic plaques start to interfere with that normal balance between prothrombic and antithrombic factors and behaviors. And what can then happen is those plaques either get, because of like shear forces, so physical stresses, the blood flowing over them, start to kind of erode, and now things inside or below the endothelium that should not be exposed to circulating blood are now getting exposed to circulating blood and trigger that clot formation inappropriately. Or there's chemical factors that are being released, because remember, atherosclerotic development is an inflammatory process. So now you start getting these chemical factors being released that then lead to inappropriate activation of the thrombogenic factors. And that can lead to an acute near occlusion or a complete occlusion of that coronary artery. And you'll see in this graphic here the visualization of the artery where, yes, you do have that atherosclerotic plaque formation, but you can still see blood's getting through it, right? Okay, let's just say it's like 70-75% stenosed. You still are getting blood through it. You still are meeting the minimum requirement of oxygen at rest, right? Because you have that blood going through it. But now, because of that endothelial dysfunction, and now those prothrombic factors are exposed to that circulating blood, that causes that clot to form quickly, abruptly, and now it causes either a near occlusion, so at least 90%, or a complete occlusion, so 100% occlusion of that artery. And now I have no blood circulating past that. Kind of think of this as a situation of like a stroke, but occurring in the heart. And I'll potentially start to see changes in my ST segments on my EKG that may point to, or at least give me an idea of where this occlusion is occurring, simply by looking at that 12-lead EKG, right? This is just a kind of a geographic map of the heart and the 12-lead EKG and what coronary arteries are supplying the blood to those regions. So, inferior wall MIs, so 2, 3, and AVF. It's your right coronary that's the problem in the vast majority of patients. Okay? So the 12-lead EKG can give you an idea of which coronary artery is giving you the problems. When you go to set out and do your history and you start to do your physical on your patients with suspected acute coronary syndromes, we want to go through our OPQRST. Granted, we're going to go through it fast. I'll show you when we talk about management what our time hacks are. This is not your 20-minute, 30-minute head-to-toe assessment kind of thing. This is direct, give me the answers I need right now so I can act quickly. So, onset, when did it start? How long has it been? Or how long did it last? Are you still having symptoms? And when did it start? Were you doing something? Were you exercising and it started? Was it you were sleeping and you were awakened because of that chest pain? Was it eating? Was it, all of those questions, all those answers are important because it kind of helps you steer your management, because it helps you classify your patient correctly. Let's talk about provocation and palliation kind of symptoms. So, what made the pain worse? So we said activity did it. Okay, all right, that makes sense. Well, what made it better? Oh, I stopped and I sat on the couch and then it went away after 10 minutes. Okay, or I took my nitro that I've been told to take. Okay, that's a little more concerning, right? And you know, is this a change in your normal pattern? So if you have a history of stable angina, is this pain exactly like that symptom, or is it now different? Because if it's different, then that's going to steer us to a completely different limb on the algorithm for treatments. What's the quality? So remember we talked about how the chest pain that we experience is not really like a pain, it's more like a heavy kind of weight, pressure, sensation. It's not a stabbing, somebody's taking a knife and stabbing me or cutting me or anything like that. It's that pressure sensation that we describe as pain. Are there any evidence of anginal equivalence? So, the other symptoms associated with either the failing heart or the not as well as functioning heart, or is it signs of that sympathetic nervous system being in overdrive because the body is sensing that there is cell death occurring because of this ischemia? Does it radiate anywhere? So we usually associate left arm, left shoulder radiation of pain as being cardiac. The right arm, we typically don't, but in some individuals, they may have that radiation down the right arm, but it's rare that occurs. How bad is it? So pain lasting for more than 15 to 20 minutes, especially at rest, is concerning for ACS. If it lasts less than 15 to 20 minutes, or it's just occurring with exertion, then maybe it's just stable angina that we're dealing with. So how long is it lasting, and when did it start is important. So you did your history, you did your physical, what else can we do to help us determine what is going on? We can get labs. So we talked about biomarkers, the troponins being our primary cardiac biomarker that we use nowadays, where you're going to take it and then you're going to then repeat that troponin a couple hours later to see if it's still rising or if it's starting to fall. Because when you look at the biomarkers, the cardiac biomarkers, you'll see you have a quick rise in your troponin, and then it slowly kind of starts to come down. So if I check my biomarkers, within an hour of them coming in, I may not have reached that threshold of that being an abnormal value. But if I were to repeat that in 3 hours, now I'm up here, and now I am definitely above the normal value, showing that there is a cardiac stress occurring in that patient. So you are going to want to repeat it. Now, this doesn't necessarily mean you're going to delay treatment based on that troponin. You're not going to be sitting there like, can't take you to catheterization because you haven't peaked in your troponins yet. This just kind of helps you identify if there is continued stress, and also kind of the severity of that stress that the patient is experiencing on the heart. So lab tests with the cardiac enzyme is important. The other important thing, of course, is your EKG. Because how do we classify STEMI ST elevation MI versus non-ST elevation ACS, right? So how am I going to assess if there's an ST elevation without an EKG component to this? So you do need that EKG to help you classify this patient appropriately, so you can determine how to manage this patient appropriately as well. When we see ST elevation on that EKG, that indicates that there is a transmural injury occurring. So the full thickness of that muscle in that area is either under stress or is dying because it's not being perfused adequately enough to meet the oxygen demand in that region. So that full thickness is under stress. Now compare that to when you have ST depressions or T-wave inversions, where this is indicative of subendocardial ischemia. So there still is a stress, but it's very limited as far as the depth in that myocardium that's being impacted. So remember that the blood supply of the myocardium does not come from the blood inside the chambers of the heart. That endothelium kind of protects that, right? So you have your endothelium, and right above that you have your subendocardial myocardium. And the blood has to penetrate through that thickness of that muscle to get to that area. This is the area that is most susceptible to perfusion defects because those vessels getting to that area have gone through a thick muscle, but they also are very tiny blood vessels to provide that oxygen. So if there is any kind of perfusion deficit or there's a problem with that supply coming to that region of the heart, this is definitely going to be the area that's going to be susceptible for injury and damage. So you'll see this in patients who are just having that isolated kind of focused perfusion deficit. So T-waves, inversions, and ST depressions. And you should remember from EKG, the way we determine where that ST segment is going is by identifying that J point and then comparing that to what your baseline should be. And based on where that J point is compared to baseline will tell you, is this an ST elevation or is this an ST depression? And this is what ST depressions are going to look like. So my baseline should be right here, right? Sorry, no bumps. So you've got this delta difference here, and it's now down from baseline. We talked about that being the subendocardial ischemia. This may be reversible, meaning that if I can decrease my demand so that the supply is now adequate, then that ischemia goes away. There isn't necessarily permanent damage that's done at this point. So you can intervene and you can fix this problem before it becomes more severe. ST elevations, remember this is the transmural, so the full thickness of that myocardium is under stress and dying. This is diagnosed, or this is identified if you have an ST segment J point elevation that is at least 1 millimeter in 2 contiguous leads, except if it's V2 and V3. So if that elevation is at least 1 millimeter in 2 contiguous leads, then that is an ST elevation. If you're looking at V2 and V3, you get a little more wiggle room with that ST elevation, depending on if you're a male or a female, or the patient is a female or a female. And what you can see is in males, you get now 2 millimeter elevation in V2, V3 before you now qualify for an ST elevation. If the patient is female, you only get 1.5 boxes, so 1.5 millimeters to be able to say that this is an ST elevation or not. So make sure you are identifying an ST elevation appropriately based on this criteria. Now, one of the other things you may see on your EKG in the setting of an ST elevation MI is Q waves, or pathologic Q waves. These are not very useful in the acute setting because these typically come on 8 to 10 hours after the injury occurred. So great, historically I can see that this patient had an ST elevation or had a heart attack, but if they were to come to you, they've had pain for an hour, they come to the emergency room, and you do an EKG and you don't see Q waves, that shouldn't falsely reassure you that this patient is okay. It just means it hasn't been long enough to actually show these Q waves developing. So pathologic Q waves give you an idea historically if this patient has had a heart attack. So if you have pathologic Q waves, what does that mean? It has to meet one of these criteria. So it's either the width of that Q wave is greater than 1 millimeter wide. Or it's 2 millimeters deep, so two small boxes down. Or it's greater than 25% of the depth of the QRS complex. So if it doesn't meet this criteria, but that QRS is very small and that Q wave is 25% or more, then that is a pathologic Q wave. Or the last criteria is you see these in leads V1 through V3. You shouldn't see Q waves in a non-pathologic condition. So, so if you do see Q waves in any one of these situations, those are pathologic and are indicative of a previous MI, whether that be 8 hours ago or 8 years ago. Okay. And this is just an EKG tracing, kind of showing you the evolving EKG changes of somebody who had a STEMI. So you start to, patient starts to have pain, don't really see much change, but then you start to see that ST elevation start to rise. Maybe it doesn't quite meet the threshold of that 1 millimeter yet, but as you continue to watch, that ST elevation now definitely gets to the point where it's above that 1 millimeter elevation, or if it's V2, V3, that 2 or 1.5 millimeters. But then 8 to 10 hours later, what do you start to see? That Q wave starts to develop, and you still have that ST elevation present. You take care of the patient, you treat the problem, perfusion is restored, that ST elevation resolves, or is resolving, but then you start to have this inverted T wave that develops. So this is like a day or two after the fact. But you still have that Q wave present. And then potentially weeks or months later, that ST elevation or that ST change is gone. It looks back to normal-ish, but you still see this persistent Q wave present. That's how you can tell if somebody, potentially one of the ways you can tell if somebody has had a history of a heart attack. Okay, so now that we kind of have that foundational knowledge of what we're looking for in the acute coronary syndromes, now let's actually apply that so we can identify and diagnose our patients with the appropriate acute coronary syndrome that they're experiencing, okay? So we talked about how the defining factor of acute coronary syndrome is that ruptured plaque, which leads to either a partial occlusion or a total occlusion of that coronary artery. When I start to see the non-ST elevation MI, ACS syndrome, so unstable angina and STEMI, you start to get that ST depression, T wave inversions on your EKG. So then that kind of helps you differentiate that from a STEMI, where you have that ST elevation. But now to help you differentiate between the two non-ST elevation ACS syndromes, you're looking at what are the biomarkers doing. In unstable angina, you don't have an elevation in your biomarkers. In a non-ST elevation MI, you do have positive biomarkers. So the troponins will be positive. And this just kind of gives you that idea. So now, one other thing to kind of talk about is, just because this patient has stable angina does not mean that if it gets worse, they're going to go to unstable, then to NSTEMI, then to STEMI. They can jump straight to STEMI from that, okay? So don't think that they have to follow this spectrum. They can go wherever the heck they want on this spectrum. So if they get that total occlusion, their stable angina, get that plaque rupture, total occlusion, they can go jump straight to the STEMI, okay? So don't be falsely reassured that you're like, oh, you can't have a STEMI yet because you haven't done the unstable angina yet. No, but you can jump straight to STEMI. So we talked about what kind of separates unstable angina from stable angina is the pain, the ischemic episodes occur with lesser degrees of exertion, so they don't have to go as much flight of stairs or go as far of a distance as what their normal is to have symptoms. You know, normally their chest pain, that pressure, they usually rate it as a 2 out of 10, but now they're going to rate it as a 6, 7 out of 10. That change in severity indicates a progression of the disease. Okay? And then if that symptoms occur at rest, this is now unstable angina, at a minimum, unstable angina. Okay? Because stable angina is that pattern of predictable behavior with exertion. So, so if it occurs at rest, it cannot be stable angina. EKG, we said, may be normal, but it may have those T wave inversions and ST depressions. If it starts to develop ST elevations, it's no longer unstable angina. You now have progressed down the spectrum, and now you have STEMI, right? And then the other differentiating thing for unstable angina from the non-ST elevation MI is the troponins are normal. If troponins become positive, you have progressed to a different form of ACS. Okay? You have to have normal troponins to remain in the unstable angina. Now an NSTEMI, okay, still non-ST elevation ACS, and kind of mimics everything else of unstable angina, but the key thing is troponins are elevated now. T waves may be inverted, ST depressions may be present, but it's that biomarker, that troponin level being positive that differentiates this from unstable angina. But you still don't have ST elevations, so this is not ST elevation MI. This is not a STEMI. And then, of course, the last of the ACS syndromes is the STEMI, the ST elevation MI, where now you have those ST elevations. They're localized, so that means it sticks to a certain geographic area, right? This is not like your pericarditis ST elevations where you may have like this diffuse kind of thing, not localized to a particular coronary artery. You may have reciprocal changes, which we'll talk about in a later lecture. And then you may have Q waves, depending on when this occurred. You may have Q waves present. So what is the complications that your patient may experience as a byproduct of this ischemia or this infarct that's occurring to their heart? Well, think of it as there's functional problems that develop, right? If the muscle is not getting the oxygen that it needs, it's going to start to shut down function, right? It's not going to just continue to function in this anaerobic state that's not as efficient, doesn't provide the energy, the ATP that's needed to keep going, right? So things, they're going to start to shut down. So what are we going to see? Well, we're going to see our two flavors of heart failure, so systolic dysfunction and diastolic dysfunction. So that's going to lead to your typical heart failure kind of symptoms, to include pulmonary congestion, so crackles, lung auscultation. You may even get that S4 present. You may even get that S3 present from that volume overload, depending on how bad, how severe this is. It may impact the papillary muscles, particularly like the mitral valve papillary muscles. So you may start to now, instead of having that one-way valve integrity, or one-way flow integrity because of that mitral valve, now that papillary muscle is not going to control the leaflets of the valve like it should, and now you start to get a regurgitation develop because that papillary muscle is not working, it's not functioning anymore. And then we talk about increased sympathetic tone because the body recognizes that the heart is under stress, so it's going to increase that sympathetic tone to try to fix the stress, but it only makes the situation worse. So now you're going to start to see potential symptoms of that increased sympathetic tone. So the diaphoresis, the increased heart rate to try to increase your cardiac output, and then an increase in that blood pressure to try to maintain a perfusion pressure, but at the expense of raising the afromode, which is only going to make the heart function worse. So how are we going to, now that we understand what the ACS is and what the different syndromes are, how are we going to manage these patients? Because they will come to you in your ERs, they will come to you in your clinic, and you got to act fast, potentially to potentially save their life. So how are we going to do this? Now we're going to use the American Red Cross 2020 version of this. There was a new version that came out with the American Heart Association in February of this year, but this is not going to be reflected in your PANTS testing yet. So that's why we're going to teach the 2025 version, and even then it's only like minor changes. But just understand that there is now a new version. So when you go through your BLS, when you go through ALS, you're going to be learning the 2025 version, so it may be different from this. Okay? So let's walk through it. So this is the algorithm on what to do with a patient that you suspect has acute coronary syndromes. Okay? This is not cardiac arrest. This is just somebody who's having a heart attack, or you suspect is having a heart attack. So let's say that you are the initial responder, or you are the EMS crew that's called to respond to this patient. What is expected of these individuals in this setting? Well, one, do your basic BLS. Okay, support airway circulation, breathing. Do CPR if necessary. Deliver shocks with an AED if you have that capability. I mean, if you're an EMS crew, yes, you may have a defibrillator. But at a minimum, try to use an AED, at least to shock if necessary. But do the basic life support stuff. Administer aspirin. So that is an expectation and a hope in that pre-hospital setting to give that. Consider oxygen, nitro, and morphine if needed. Obtain IV access, but do not delay transport for the IV. Obtain that 12 lead EKG if you have the capabilities of doing it. And if you have the capabilities of doing it, do you have the capability to send this to the receiving hospital so that they can look at the EKG and get their systems activated appropriately? You want to communicate if there is especially a STEMI evident on that EKG. And then, of course, don't sit there on the football field with this patient. Get them to the emergency room as soon as possible. Now, you'll notice aspirin you're going to do, but then there's these caveats to oxygen, nitro, and morphine. So there is certain patient scenarios where you do administer those types of things. This could also apply to your primary care clinic you're working at. So Jennifer Marino is a BLS facility. Even though they have doctors, even though they have PAs, even though they have nurses, even though they have medics, foremen, techs there who could do ALS, they do not have the equipment to do ALS. So Jennifer Marino would be responsible for doing this. So they would give the aspirin, maybe oxygen plus or minus, maybe nitro plus or minus. They do have nitro, and plus or minus morphine, which they probably don't have morphine in their little cart, their rapid response cart. If they needed it, they would get it from a pharmacy, so that's going to take some time. It's going to delay transport and everything like that. So maybe not something that Jennifer Marino would do, but maybe your ambulance would have the capabilities of doing this. So this is the pre-hospital setting. Now, in the hospital, within 10 minutes, so your time hack for this is within 10 minutes of them arriving, this is what you need and should do. if it's a STEMI, activate the STEMI protocol. So what is that going to do, or what does that mean exactly? Well, it kind of depends on your facility. So here at BAMC, we have a full STEMI team that can respond. You have cardiologists, you have interventional cardiologists who are on this team who will respond immediately to their extent and capabilities. So it's not going to be just solely on the ER department and the crew to manage this patient. When they activate this STEMI team, they're going to get the additional resources that they need in order to prep them for the next step, next stage in their management and treatment. How is that activated? Kind of depends on your facility. So it could be you call the operator and tell them that you have a STEMI in the emergency room, and then they go out over the intercom system over the hospital and do that STEMI alert. Some facilities may have a button that you push that activates the STEMI alert, similar to like the code blue buttons that you'll see in patient rooms. So it kind of depends. Now, the capabilities also may depend on your facility, because if you don't have cardiologists on hand, then it may be just on the emergency department's capabilities to manage this patient with a STEMI. If they don't have the ability to do catheterizations in your facility, then you're not going to have all of that personnel kind of responding and getting that room ready to go to bring that patient to get that catheterization done. So it really kind of depends on the capabilities of your facility and the standard procedures. So what I would recommend is when you get to a new facility, in the orientation, this is something that should be reviewed with you so that you know if this is activated, who needs to respond, especially if you're on that team that needs to respond. And two, how do I alert and activate this emergency system? Sorry, if needed. So activate STEMI team per protocol, and then I'm going to do my basic life BLS kind of assessments. So airway, breathing, circulation. See if I need to do anything to support that. I'm going to get my vital signs, and I'm only going to give oxygen to this patient if their oxygen levels are less than 90%. So if they're 94%, they don't need oxygen. If they're 92%, they don't need oxygen. Only when that oxygen on the SpO2 monitor gets below 90 that they should be at or should receive supplemental O2. And when you do identify a patient who needs supplemental O2, you're not shooting for 100%. You're only shooting between 90 and 99%. Okay, so you're not hitting them hard, or you're having to do like a BiPAP, CPAP, or intubate to get their oxygen levels up to that 100%. You can just put a non-rebreather on and titrate up to 95, and you're good. Get that EKG, especially if it hasn't been done already. It's probably good practice to get a repeat EKG just to see if there has been any changes on the EKG since the emergency crew got theirs. Get labs. And then do a brief medical history. Now remember, this is within 10 minutes. So this is not your 20-minute ClinCore assessment of your patient. So you're going to be cutting out a lot of things and just going directly at the pertinent things to help you with this ACS patient. Do a very focused physical exam, and then review complete fibrinolytic checklist, which we're going to talk about why that's important, and then obtain chest radiograph within 30 minutes, but do not delay cardiac intervention if possible. So one of the things when we look at medicines, so immediate general treatment, so aspirin if they haven't gotten it, they should have hopefully gotten that in the pre-hospital situation. They may have gotten nitro, may not. If they're still having active pain, give them nitro. Morphine if discomfort is not relieved by nitro. Okay? So this is not everybody gets morphine because they're coming in with acute coronary syndromes. Only give morphine if the discomfort is not being relieved by nitro. So let's go back to our algorithm and look and say, okay, we looked at our EKG. I have now diagnosed this as a STEMI. So this patient has an ST elevation. Hopefully we've already activated the STEMI team because it said it to do that in the other box, right? And then this is where your history is important. So has it been less than 12 hours since the symptoms started? If this is somebody who is coming to you and it's been 14 hours or so since they've been having this chest pain, then you're outside of the window for this treatment algorithm potentially, okay? But if it's been less than 12 hours, then if we can do PCI, so we can do a catheterization in our hospital, the goal is within 90 minutes, they're in the cath lab and they're getting their procedure done to fix that perfusion deficit. If, for whatever reason, so like for instance, this patient presents to Jennifer Moreno, and I cannot do a PCI in there at Jennifer Moreno, I now have 120 minutes basically to transport them from first contact to the cath lab. So can I, within 2 hours, get this patient from Jennifer Moreno to BAMC to the cath lab at BAMC? Hopefully so, but stranger things have happened, right? If I am not a PCI capable facility, if I cannot transport them to a PCI capable facility within that 120 minutes, then I'm going to do fibrinolysis. And the goal is that they're getting that fibrinolysis within 30 minutes of that first contact with medical personnel. Okay? So those are our time hacks to manage a patient with a STEMI. Yes?
In this kind of setting, you still do a right-sided ECG?
Typically you do. So if only if, I take it back. If you do the EKG, probably you see an inferior wall, STEMI, then yes.
Which would be what we're talking about, right? The
V2,
V2,
V3, with the additional ST elevations in V2, V3, that'd be more of an anterior septal kind of area. But if you're talking about a 2-3 AVF, yes, then that's your inferior wall, and that's where you definitely would do that right-sided EKG.
Okay.
Yep, before you're doing nitro and before you're doing morphine.
Okay.
Correct. Yep. Yep. Yeah.
Haven't they disproving the whole nitro and right-sided inferior MI?
Literature is still, more studies need to be done. Because the other thing too is you also are getting evolving medicines. So maybe the nitros of today are not like the nitros of 20, 30 years ago where there was that preload effect. But the studies are still, we need more, basically, what it comes down to. So you'll have some folks who are going to be just aggressive and immediately go do that. Others are still, because of the dogma of education of don't ever do this, it sticks with us, and so we are hesitant to change. So, yeah. Let's go ahead and take 10 minutes, come back, and then finish up. We have in practicing medicine where it's like, well, this guideline says to do this, but this study shows that maybe that's not correct. What do I follow? And unfortunately, you're kind of left in a state of, if a bad outcome happens and you weren't living up to the standard, you have to justify why you weren't living up to that standard, and because otherwise it could be malpractice. So you're kind of left without that safety net if you go away from the standard in this situation because of a study or something like that that came out. So that's why there's hesitancy to change the standard, even when studies start to come out to support changing that standard. So, so that's a very frustrating thing about taking care of patients in modern medicine. Because of course none of this was a problem, 150 years ago. We were just using leeches and bloodletting and all that kind of stuff, right? That was the standard of care.
Restrict as heroin.
What's that?
Restrict as heroin.
So, but yeah, That's the problem with modern medicine. Our treatments become very sophisticated that they don't apply to 100% of our patients. And also, not all of our patients are going to respond to the same medicines the same way, right? You have different genes that are activated that delay the breakdown of a medication to an active form, or delays breaking down the active form, so they need lower dosages and stuff like that. So that's probably the future of medicine, is coming up with individualized therapies based on the genetic expression of the patient. So it should be interesting in the next 50 years what happens. So we finished talking about what to do with a patient with a STEMI. But what do we do when you have a patient who's coming in with a non-ST elevation ACS syndrome, acute coronary syndrome? Well, our algorithm, our American Red Cross algorithm, does have this on it as well. So once you have identified by EKG that this is a non-ST elevation, then it says complete a risk scoring tool using a validated tool. Great, which one? Oh, I'll talk about it on the next slides, but it's not specific. And that's the unfortunate thing, because this is an American Red Cross thing, so this is an American thing, and so you would think that they would have our Americanized validated tools to use for this, right? But it just leaves it vague. If you use your tool and you identify this patient as high risk, or the EKG finding is highly suspicious of ischemia and or a high risk score, then you're going to consider early invasive strategy. So these are patients, even though they don't have an ST elevation MI, are going to go to a PCI facility, or get PCI to fix whatever that perfusion problem deficit is and treat the condition. Consider dual antiplatelet therapy and anticoagulant therapy, so an aspirin and P2Y12 inhibitor, and anticoagulant. So that's what you're going to do if the patient is high risk for ECG finding highly suspicious of ischemia. If, according to your validating your risk score is low or intermediate, normal EKG or non-diagnostic, and they have a low risk score, consider an admission for monitoring further and or outpatient follow-up testing. So these are patients who could be discharged from your ER to go see you in the primary care clinic. Great. It's not what I want to go with, right? I want to go to the cardiologist. But they may come back to you even though they've been diagnosed with unstable angina, but otherwise low risk and stuff. So what is a validated cardiac risk tool you can use? The most common one that we'll use in the United States is the HEART score. Don't remember this, or don't memorize this chart. Just learn this part here, okay? So somebody is considered low risk if they have a score of 0 to 3 on it. They're intermediate risk if they're 4 to 6, and they're high risk if they have a greater than 7 score. So when you look, again, don't memorize this chart, but when you look at the thing, so based on the history, how suspicious are you that there's a cardiac event going on? Slightly, moderate, high. Okay. EKG, 1 point for non-specific repolarization disturbance. Or if there's a significant ST deviation, then you get 2 points. What's their age? Okay, what are their risk factors? How many of these risk factors do they have? And then what's their initial troponin? So basically, what you're going to do is you're going to get all that, you're going to get that history, you're going to do that assessment, and then you're going to plug in that data into this tool, and then you're going to see what is their risk. Now, highly, highly, highly recommend that you download the MD Calc app on your phones. It's free, which is great, but it has all of these tools, these risk stratification tools, calculators, and all this kind of stuff built into it, so you don't have to memorize these things. But it still gives you that objective data that you need to help you with your medical decision making. Why is it you had this chest pain patient and you decided to discharge them from the ER? Why is it you have this chest pain patient and you consulted cardiology? Why do you have this chest pain patient and you called for them to get admitted to get a PCI done? This risk stratification tool gives you that objective data to help you make those decisions. And this is important data when you consult the cardiologist. If you're like, yeah, I got a patient I'd like you to see, he's got a heart score of 0, but I'd like you to see him. Okay, the cardiologist is probably going to push back on you, right? But you're like, hey, I got a patient who's got a heart score of 7, they're not even going to let you finish your statement. They'll run it down to the ER, right? So, use this tool to help you with your medical decision making. Another tool to help you with your medical decision making, and this is in addition to the heart score, is your TIMI score. Okay. Now, there's 2 versions of the TIMI score. There's the one for unstable angina and STEMI patients, and then there's one that's for STEMI patients. Okay. But the reason or the point of using this tool is it helps give you objective data based on studies of what is the risk that this patient with unstable angina or NSTEMI in the next 14 days is going to die. Okay, so that's what the TIMI score is going to tell you. And that's important data because it's like, great, you're okay right now, but you have a 41% risk of dying in the next 2 weeks. How's your patient going to feel about that risk? And you just discharge them from the ER, right? So this is an additional scoring tool that's used to look at a different decision point. So great, they may be intermediate risk on the heart score, but they have a 41% risk of dying in the next 2 weeks with this. So maybe we should probably be more aggressive in treating them. But again, I don't expect you to memorize the TIMI score as far as what goes into it. Just memorize or recall that as you go higher in that score, you're increasing your risk of mortality in the next 2 weeks. Again, that calculator is on MDCalc. Now, the medications that are included as part of your American Red Cross algorithm for treatment of ACS, this is what it looks for. So, aspirin, okay, they want you to do 162 to 325 milligrams chewed. This is important. You want the chewable aspirin for this. You don't want that daily baby aspirin that's enteric coated, because you want something that's going to act quickly, right? So the chewable aspirin is going to be important to have, not the enteric coated. Because the enteric coated is protected, so it decreases your risk of GI bleeds, which means that it's going to delay the breakdown and the absorption of the medication. So 2-3 hours from now, you may start to have an effect from that aspirin. How useful is that in a situation where I'm talking about minutes? I want something working, right? When you get to your first unit, especially if you're going operational, check your crash carts or your rapid response carts and make sure the aspirin that they have in there is chewable aspirin, not enteric coated. I got to my ship prior to coming here back in 2021, and they had enteric coated aspirin in my crash cart. So that got pulled immediately and replaced. Nitro, okay, do the sublingual every 5 minutes up to 3 times. Now morphine, if discomfort not relieved by nitro. And this is important because some of the new, this is an FYI slide, but some of the new literature that's starting to come out is actually showing that morphine may be contraindicated in this patient population based on this early ACS trial that they did, and there's been some multiple meta-analysis studies that have been done as well on this. But these studies have shown there's an increase in in-hospital mortality and recurrent myocardial infarction in patients who had morphine. So we're trying to use morphine to help treat our patients, but we actually may be doing more harm to them than good. This is controversial still, which is why you still will see in the protocols morphine is still included, because the experts haven't really bought onto these studies yet. I will say though, some facilities have. So BAMC, I'm told, does not use morphine anymore in their patients with ACS. They've jumped on the bandwagon for this and not giving ACS or morphine in the ACS patients. You know, the thought process with why this is a problem is that they think that morphine may negatively impact platelet function. So instead of now having that aspirin or the clopidogrel working to inhibit platelets from clotting, that morphine kind of upregulates and actually encourages a clot to form. And so that leads to the recurrence of a heart attack, which then can lead to increased mortality, because now you already have a heart that's been damaged by an event, and now I'm having another event from potentially a side effect from morphine. One of the reasons that this is still controversial is is this a causation or a correlation question, right? Do we see in vitro, like in a test tube, do we see this as a problem? Or is it, if I go back a slide, I am selecting for high-risk patients to have recurrent MIs. If I'm only giving morphine out to people with persistent chest pain despite nitro, is that patient already at a higher risk than somebody who had their pain relieved by nitro? That's the question. So again, it comes down to causation versus correlation. So are we selecting our patients for morphine who already are at risk of having worse outcomes? So that's more to come, more to follow on the use of morphine as part of this. I think so. I've read both. So I've read that it affects like aspirin and clopidogrel, and I've also read that it actually affects the the platelets themselves and activates that clotting, and so it overrules that antiplatelet effect of those medications. So I think it's like we don't know. We just are seeing this bad outcome in patients who take morphine. All right. So what medications are we going to give and why? So we're going to give aspirin. We talked about that being one of the most important things. Hopefully we can get this pre-hospital. The sooner the better, right? Because aspirin can decrease vascular mortality by 2.4% if it's administered to your patient, especially early on. So I already am improving my mortality chances. If they can't take aspirin, then definitely give them clopidogrel. And then they're going to be on antiplatelet therapy. If they undergo PCI and get a cardiac stent placed, they're going to need to be on dual antiplatelets. So they will be on aspirin and clopidogrel, or one of the varieties of antiplatelets that are out there. They'll be on at least 2 medications. Your fibrinolytic therapy for those folks who you cannot get them to a PCI facility within those time hacks, then giving them TPA or giving a fibrinolytic is important, because we said that what's causing the acute coronary syndrome is that plaque rupture leading to clot formation. So let me break up that clot with that fibrinolytic therapy. So now I have gotten rid of that clot with the TPA, and now blood hopefully is being restored to that area that was under stress or dying, because I've gotten rid of that clot and I've restored blood flow. The problem with this is you're not done with therapy once you give them these fibrinolytics. you need to then also go, and they'll do this down the road. It might be a couple of hours, maybe a couple of days after fibrinolytic therapy was administered, but they're going to undergo a cath procedure to do a rescue PCI because I still have that obstruction, I still have that unstable plaque that led to that acute occlusion that needs to be dealt with. The fibrinolytic therapy does not do anything to that plaque. It just gets rid of that clot that formed that caused the acute occlusion. So these folks are going to go through PCI and hopefully get a stent placed to fix that perfusion stenosis. Nitro. So nitroglycerin gets broken down into nitric oxide, which is a potent vasodilator. So it's going to open up your vessels, and hopefully by increasing that lumen, you're going to open up the artery so that blood, at least some blood, can get past that obstruction and limit the disease or the impacts of that occlusion that we said. Okay? And again, still questionable based on some recent studies, but we still teach avoiding nitroglycerin patients with hypotension or right ventricular infarction. So that's why your right-sided EKG would be important if you have an inferior lead or inferior MI present on your EKG. So you don't want to necessarily give nitro to those patients because it could make that right-sided heart failure worse. Now, some additional medications that are not necessarily part of like your MONA B is beta blockers. Well, beta blockers actually are part of your MONA B, but and the reason that we like to give beta blockers is, one, I decrease my heart rate, so I'm decreasing my demand, I'm preventing my heart rate from speeding up, increasing that demand where that supply problem is still maybe persistent, which is great. So I prevent that recurrence. But studies have actually shown that beta blockers improve mortality because long term it actually prevents adverse remodeling of the affected area. So you have a scar that forms from that muscle dying, right? But what's going to control that scar formation from interfering with normal myocardium? Beta blockers have been shown to limit that scarring to just the affected area, so you don't have collateral damage occur from that scarring process. Okay? So it preserves myocardium, it preserves myocardial function and limits that adverse remodeling. So that is why, and that is how beta blockers provide that mortality benefit that you don't see with calcium channel blockers. Because even though calcium channel blockers will do the same thing for the demand, it will decrease that demand, calcium channel blockers don't do anything to prohibit or prevent that adverse remodeling that occurs after the event. So that's why you don't get that mortality benefit long term with calcium channel blockers. Some additional meds, so ACE inhibitors are recommended. I mean, it reduces the afterload, which is great because that will help with your cardiac output, right? But the reason we say specifically ACE inhibitors or an ARB, if they can't tolerate ACEs for some reason, and not like HCTZ or calcium channel blocker, is because ACE inhibitors also limit adverse ventricular remodeling. So similar to your beta blocker, they will limit that that scar formation to just the area that was damaged and affected by it. And then finally, statins should make sense. If this was because of a plaque formation, atherosclerotic plaque formation, let's go ahead and start treating that disease that led to that. But the other thing it does is it actually stabilizes that atherosclerotic plaque so that you don't have that rupture recur to cause that acute clot formation in that area that caused that occlusion of the coronary artery. So statin therapies are important, not only from the atherosclerotics part, but also stabilizing the plaque to prevent that acute plaque rupture again. So let's look at our revascularization procedures. We talked about these in the ischemic heart disease lecture, so we'll go through it a little quicker. But we talked about how PCI is a mainstay treatment for a STEMI, and that is the optimum treatment for a STEMI. And the reason for it is that if we can do it, you have a 95% success rate at restoring blood flow to a diseased coronary artery. And just remember what your time hacks are for getting patients to the cath lab based on where you're at, what your facility capabilities are, and stuff like that. Otherwise, if you can't meet those time hacks, then you have to or should be administering the thrombolytics, so fibrinolytics. Okay. Cabbages is the other option that we do from a revascularization. More invasive, more morbidity and mortality than with PCIs. But there are certain situations like diabetics, large geographic area that's being affected, LAD, left vein, those kind of things, where maybe a cabbage actually is the preferred option over a PCI to treat these. And the link that I included there is kind of an exhaustive list of patients who would benefit from a cabbage over PCI. So let's finish up our lecture today talking about complications post-MI. So you did everything when they initially presented acutely, their pain is resolved. Yes, they have some residual damage from the heart attack that they experienced. We're not out of the woods yet. Okay. There are things that we need to watch this patient for carefully as far as complications that develop as the condition, as the healing process develops. Okay. And there's quite a few complications to kind of be alert for. And we'll walk through each one of these here. So, recurrent ischemia. So they had a heart attack. What were the conditions that led to that heart attack in the first place? They're still there, right? Potentially. Or at least the setup for that condition is still there. How do we manage that to prevent them from having another heart attack? You know, the key thing would be to get those revascularization procedures done, because if we didn't do anything, let's just say we treated them with the fibrinolytics and that's all we did, so we treated that acute issue, 20 to 30% of patients are going to have a recurrence of this. PCI, the reason that we push for PCI if possible over just fibrinolytic therapy is this rate is much, much lower if these patients have a PCI done instead of just thrombolytics, because this rate is not changed by the use of thrombolytics. So they still have a 20 to 30% chance of recurrence even though they got thrombolytics, as the setup is still there that led to the condition to develop in the first place. You just treated and addressed the acute issue of it. Arrhythmias are a major concern after this because, you know, in the myocardium, within the myocardium, runs your conductive pathways, right? And if those conductive pathways are put under stress, or the cells of the conductive pathway die, then you are set up for developing arrhythmias. And you already have a stressed heart, let me now add an additional stressor, meaning that discoordination of the contraction of that cardiac rhythm. Now that additional stress may be enough to cause death. And you can see some of these are life-threatening arrhythmias that could develop. And this is probably the most common cause of pre-hospital mortality from a heart attack, is that heart attack happened, they developed a life-threatening arrhythmia, and of course, we didn't have the medical expertise there to kind of take care of and address that arrhythmia, and the patient dies. And these stressors, and the reason that this is additional stress is when you have that heart attack, you get those toxic metabolic products that then lead to a disruption of the normal conduction of the action potentials. You also have autonomic stimulation. So you go into like a sympathetic overdrive, and now that causes increased heart rate, which then leads to furthering the demand-supply mismatch. So now your demand is higher than what it should be, and now that's leading to even more cell damage because you're not perfusing appropriately. The other reason is the vital areas of the conductive pathway have perfusion from the coronary arteries. So if you have a perfusion deficit affecting that coronary artery, then you could be permanently damaging or affecting the conductive pathway structure. So if I have a right coronary artery occlusion, especially high up, 70% of patients receive their blood supply to their SA node from the right coronary artery. So now I just knocked out the SA node. What's that going to do to your conductive pathway, right? 85% of your patient's AV nodes are going to be supplied by the right coronary artery. So now I have right coronary artery occlusion. I now have knocked out my SA node and my AV node. Imagine what the implications are if those two structures are knocked out. Okay. Looking at the next complication, post-MI complication, it's now you have the myocardial cells are dead, they're not functioning anymore, so now you're losing a strength of squeeze, so you're losing that contractility. If that loss of function is bad enough, it can then lead to heart failure because now you're not circulating that blood out like you should. So you're not necessarily taking 55 to 60% of that blood in the ventricle and getting it out with every time it squeezes. So now that's going to, now you have 40, 50, 60% of that blood remaining in the ventricle. What are the upstream effects of that? Because now you have all this blood trying to get back to the heart, but it has nowhere to go because it's already full. And also, what are the downstream effects of it, where now I'm not circulating that cardiac output that I need to provide oxygen to the vital organs. So you're going to potentially start to see symptoms of heart failure, so pulmonary congestion, peripheral edema, JVD, all those types of things can start to develop in the setting of cardiac dysfunction. Cardiogenic shock. This is a major problem because it self-perpetuates the problem, making it more severe and more severe. So in conditions where the heart function is so badly affected that I can't even maintain a systolic blood pressure greater than 90, what happens? Well, because I have that decreased contractility, I have that hypotension, so that less than 90, well, that reduces my coronary artery perfusion, so now I'm already in a diseased state, and now I'm not perfusing the coronary arteries appropriately. Well, that's going to lead to even more ischemia, which is going to lead to even more cell death, which then further damages my contractility, and then that decreased contractility further then perpetuates that I can't provide an adequate cardiac output, so my blood pressure starts to drop, I reduce my coronary artery perfusion, which then increases my ischemia, which then, and you can see how this self-perpetuates, and this is like a death spiral for your patient. And you can see 70% of your patients with cardiogenic shock are going to die. Right ventricular failure. So this would be your right-sided heart failure. So you start to see that peripheral edema, JVD, and all that kind of stuff start to develop. If that ischemia affects the papillary muscle, where now either the papillary muscle stops functioning because it's not getting enough oxygen, or that papillary muscle dies and now you get a tearing of that papillary muscle. Now I no longer have control of that valve leaflet, and that valve leaflet now is going to be potentially flapping in the breeze, leading to regurgitation. And we're talking about the left side of the heart, we're talking about mitral regurgitation. If we're talking about the right side of the heart, now we're talking about tricuspid regurgitation. If we had a transmural infarction of the ventricle wall, and now I have cell death that goes the full thickness of that muscle, now I lose that integrity, that strength of the muscle, and when you have systolic pressures being generated in that left ventricle, it can cause that wall to rupture, and now you're bleeding out from the left ventricle, potentially in the pericardium. And that can lead to cardiac tamponade and death quickly because you're bleeding out from the heart. But what happens if instead of that being on the ventricular wall, it's actually in the ventricular septum, so between the left and the right ventricles? Well, you can get a rupture of that ventricular septum, and now you get like this VSD kind of thing that's acquired. It's not something you're born with. You acquire this problem, and now you're having blood going from the left ventricle to the right ventricle with that path of least resistance. Another thing that could happen is this ventricular aneurysm. So the wall of the ventricle, because of that weakness, it may not rupture, but now because of that, you lose that integrity and kind of keep everything inside where it should. Kind of think of this as like the hernia of the heart muscle. You start to kind of get this ballooning effect, and that leads to stagnant blood in that area. It's at risk of bleeding, or it's at risk of rupturing, so then you could have a free wall rupture because of this weakened wall. But that stagnant blood can also then tend to the formation of clots. When blood is stagnant, it clots. So now you have a clot that forms in this aneurysm. What happens if that clot gets out of the aneurysm and back into the ventricle and gets shot out of the aorta? Stroke. And we'll talk about some other types of diseases in our next lecture that are kind of like other artery strokes you can see that affect vital organs. So that can develop. And then pericarditis. We talked about pericarditis in block 1. We'll just hit it again, where you can develop pericarditis after an MI. It's called acute pericarditis if it happens within 2 weeks. If it happens more than 2 weeks after the MI, it's called Dressler syndrome. It's going to look like pericarditis, act like pericarditis, and everything like that. You may even think that this patient's having a recurrence of their heart attack with this. But remember, from a treatment standpoint, avoid ibuprofen, avoid indomethacin, treat them with aspirin and colchicine in this situation particularly, because you want to limit the effects of that scar formation, because that could lead to a weak scar, which then could lead to ventricular wall aneurysms or ruptures. And then if you have an area of the heart, especially like if you think of the apex of the heart, that's damaged because of this heart attack, and now that area is not squeezing appropriately, that then leads to stagnant blood, which leads to blood clots, which then can lead to thromboembolic disease. So these are all of the potential complications that even after you've provided the best treatments and therapies to treat the ACS, you have to be careful of, because these can develop even weeks after the heart attack. Questions? All right, sweet. So we'll meet again tomorrow at 08, and we're going to talk about peripheral arterial diseases, aortic diseases, and then on Friday, I think we meet again.